My name is David Rosenblum. I'm an interventional pain physician in Brooklyn, New York at AABP Pain Management. I'm also a the creator of the NRAP Academy, where we do board prep, CME training, as well as ultrasound and regenerative medicine training in person, online, and with shadowing opportunities. And today I'm going to talk about how to treat acute pain in and out of the primary care clinic. When a patient presents with acute pain, any clinician needs to first go through the pathways of first making sure that this is not a life-threatening injury. If it's chest pain or upper back pain, make sure that there's no vital sign abnormalities that would suggest something like a pneumothorax or an aortic dissection. But when it's established that this is non-life-threatening, the next question is, what's going on? Is this patient drug seeking? Are they here for medication? Or what is causing the pain, and what can I do about it? And having a pain specialist or imaging is not always readily available, and sometimes you just need to do something right then and there. It varies from problem to problem. If the pain is, I'm going to start from head to toe just to keep it simple. If the pain is related to a headache, well, you want to make sure, of course, there's no subarachnoid hemorrhage, but that takes time. You want to triage the patient to the appropriate specialist or imaging that can evaluate. But if it appears to be non-life threatening, you may consider starting with Tylenol and NSAIDs. If that is not effective, at least in my office, and I understand many primary care clinicians may not be comfortable with this, but perhaps in the emergency room, once it's realized that this is non-life threatening, one nice way to terminate a headache of various causes is the sphenopalatine ganglion block, which traditionally was done with a needle inserted through the nose. But when doing it in our office, we're actually using a small tube. So there's no needle. You're just squirting about 0.5 to 1 milliliter of lidocaine 2% into the patient's nose, aiming upwards towards the mucosa in the nasopharynx, and letting the patient lie supine with the head tilted back to allow the medication to pool and diffuse across the mucosa to anesthetize the sphenopalatine ganglion. What this does is this anesthetizes the trigeminal ganglion, which is involved in many headache syndromes. Even if it's an occipital nerve involved in the headache, there is communication between the two nerves. And I find that many patients will get resolution of symptoms within 10 to 20 minutes. This most definitely does not work for all headaches, does not work for all migraines. However, I've had some amazing success with this. I've even treated post-operative eye pain with this and trigeminal neuralgia. So it's just something that's very safe. The big risk with this is nosebleed, because you're sticking a tube or an angio catheter into the nose. And then since you're squirting a local anesthetic, the throat can become numb, and there may be a risk of aspiration if the patient eats right away. So just tell them not to eat right away. But that's a pretty safe and effective way to treat acute headache or facial pain. In terms of other pain syndromes, such as the shoulder, well, once again, you start with the anti-inflammatories. I would say if you're not comfortable doing injections and you're going to refer the patient, if there's no contraindications, ketorolac 30 milligrams is quite effective. In terms of analgesic potency, it could be equal to as much as 18 milligrams of morphine without any of the CNS side effects. It's a really effective painkiller, but you need to make sure that the patient is well hydrated. They're not taking other NSAIDs, because there can be a lot of side effects. If it was chest pain, unless it's related to some obvious rib fracture or post-mastectomy syndrome, I would definitely send them for EKG, X-ray, emergency room workup, etc. Abdominal pain, similarly, you want to find out if it's visceral or somatic. Typically, the patients who come to my practice suffer from chronic pain, maybe acute exacerbations. But if a patient is having acute abdominal pain, that's an indication to go to the emergency room for further evaluation. And I'd be cautious with prescribing NSAIDs if there's a suspicion of a ulcer, or opiates if there's a suspicion of some sort of ileus or bowel obstruction. You can do it if properly monitored. You have to be very careful, though. In terms of acute knee pain, well, look at the knee. Is there an effusion? Does it need to be drained? Not every clinician is comfortable with interventions, so you might need to refer it out. But in the meantime, you could administer ketorolac or an NSAID or even if you have to, give some stronger medications such as a tramadol or Nucynta, or even an opiate temporarily. Of course, you need to risk stratify, understand who your patient is. There's also a new drug that works on the sodium channel called the suzetrigine or Journavex, and this is a drug that is in its own unique class, acting on the neuron itself and the receptors to reduce pain. It's indicated for acute pain, and it has been shown to be quite helpful. So this is a new adjuvant to our arsenal of non-opiate therapies for patients in acute pain. And as of now, I believe it's only been studied for 2 weeks. So the jury is out for longer, but if it's acute pain, this may be a great option for the patient. You take 2 pills for the loading dose, and then you could take it every 12 hours after that. And of course, any long bone pain, you need to rule out fracture. If a patient comes in with acute hip pain, there could be suboccult fractures. So you need to get imaging. So I would say, generally speaking, when there's an acute pain syndrome, you need to first rule out any sort of life-threatening injury, then figure out if it's safe to give the patient an NSAID, which is typically indicated for really severe acute pain, um, prior to giving opiates if there's no contraindications, and refer to the appropriate specialist. Imaging would be paramount, as well as possible referral to orthopedics. Interventional pain would be a nice route to go if you think it's non-operative, because we do basically everything else that the orthopedic does that's non-operative for the most part, except for casting and splinting. And we could treat it with injections, aspirations of joint, etc. So this is just a general way. Of course, if somebody has a headache, be very cautious. Rule out something more severe, or if there's a low index of suspicion of something severe going on, you could treat them with the means I've mentioned in this video. Anyway, if you would like more information on learning interventions, go to nrappain.org, or if you're a patient looking to see a pain doctor, go to aabppain.com or email me. I'll be more than happy to talk to you. Thank you.